Hello and welcome to the topic Therapeutics of Ischemic Heart Diseases in the Cardiology module. By the end of this topic, you should be able to outline the approach to management of ST elevation MI, non-ST elevation MI, and stable angina, describe the mechanisms of action of drugs used in the treatment for acute coronary syndrome, and define the fitness to drive criteria in accordance to the DVLA. Let's get started. Acute coronary syndrome or ACS is a very common and most important presentation in medicine not to miss. As we already understand, ACS can be divided into STEMI, which is XT segment elevation and raised biomarkers of myocardial damage, and non-STEMI, which shows ECG changes but no ST segment elevation coupled with raised biomarkers of myocardial damage. And lastly, we have unstable angina. The management of ACS depends on the particular type. So NICE management guidance groups the patients into two groups, which are STEMI and non-STEMI or unstable angina. Let's first look at the common management of all patients with ACS regardless of the subtype. The initial drug therapy would be oral aspirin 300 milligrams, oxygen if the patient has oxygen saturation of less than 94%, in keeping with the British Thoracic Society oxygen therapy guidelines. Morphine should only be for patients with severe pain. Nitrates can be given either sublingually or intravenously, and it should be used in caution in patients who are hypotensive. The next step in managing a patient with suspected ACS is to determine whether they meet the ECG criteria for STEMI. The STEMI criteria: clinical symptoms consistent with ACS, generally 20 minutes duration and more, with persistence more than 20 minutes, and ECG features in more than 2 contiguous leads of 2.5 mm ST elevation in leads V2 to V3 in men under 40 years, or 2 mm and more ST elevation in leads V2 to V3 in men over 40 years. 1.5 mm ST elevation in V2 to V3 in women, 1 mm ST elevation in other leads. New left bundle branch block should be considered as a myocardial infarction unless there is evidence otherwise. As for management of ST elevation MI, once STEMI has been confirmed, the first step is to immediately assess eligibility for coronary reperfusion therapy. There are two types of coronary reperfusion therapy, which is primary coronary intervention or PCI, and it should be offered if the presentation is within 12 hours of the onset of symptoms, and PCI can be delivered within 120 minutes of the time when fibrinolysis could have been given. So you would also consider fibrinolysis if there's a significant delay in being able to provide PCI. If patients present after 12 hours and still have evidence of ongoing ischemia, then PCI should still be considered. Drug-eluting stents are now used. Previously, bare metal stents were sometimes used but have higher rates of restenosis. Radial access is preferred to femoral access. Further antiplatelet prior to PCI, and this is termed dual antiplatelet therapy, which include aspirin and another drug. If the patient is not taking an oral anticoagulant, you may initiate the patient with prasugrel. And if taking an oral anticoagulant, you can prescribe clopidogrel. Drug therapy during PCI would be unfractionated heparin with bailout glycoprotein 2B and 3A inhibitors. These are for patients undergoing PCI with radial access, and this is the action of using a GPI during the procedure or glycoprotein inhibitor during a procedure when it was not intended from the outset. So for example, because of worsening or persistent thrombus, patients undergoing PCI with femoral access would receive bilavirudin with bailout glycoprotein inhibitors. Other procedures during PCI that can be considered would be thrombus aspiration, but not mechanical thrombus extraction should be considered. Complete revascularization should be considered for patients with multi-vessel coronary artery disease without cardiogenic shock. As for fibrinolysis, it should be offered within 12 hours of onset of symptoms if primary PCI cannot be delivered within 120 minutes of the time when fibrinolysis could have been given. A practical example may be a patient who presents with a STEMI to a small district general hospital that does not have facilities for PCI. If they cannot be transferred to a larger hospital for PCI within 120 minutes, then fibrinolysis should be given. If the patient's ECG taken 90 minutes after fibrinolysis failed to show resolution of the ST elevation, then they would require transfer for PCI. If patients are eligible, they should be offered as soon as possible. Fibrinolysis used to be the only form of coronary reperfusion therapy available. However, it is used much less commonly now given the widespread availability of PCI. Patients undergoing fibrinolysis should also be given an antithrombin drug. An ECG should be repeated after 60 to 90 minutes to see if the ECG changes has resolved. If patients have persistent myocardial ischemia following fibrinolysis, then PCI should be considered. Let's take a look at the types of stent. We have the bare metal stent or BMS, drug-eluting stents or DES. DES stent is coated with paclitaxel or rapamycin, which inhibits local tissue growth. Whilst this reduces restenosis rates, the stent thrombosis rates are increased as the process of stent endothelization is slowed. Following insertion, the most important factor in preventing stent thrombosis is antiplatelet therapy. Aspirin should be continued indefinitely. The length of clopidogrel treatment depends on the type of stent, reason for insertion, and consultant preference. In the treatment of non-STEMI or unstable angina, fundoparinox should be offered to patients who are not at a high risk of bleeding and who are not having angiography immediately. If immediate angiography is planned or if a patient's creatinine is more than 265 micromoles per liter, then unfractionated heparin should be given. Let's talk about the risk assessment. The Global Registry of Acute Coronary Events or GRACE is the most widely used tool for risk assessment. GRACE score is used in high-risk non-STEMI patients to consider doing early invasive management as opposed to delayed intervention. It can be calculated using online tools and takes into account the following factors, which are age, heart rate, blood pressure, cardiac and renal function, cardiac arrest on presentation, ECG findings, and troponin levels. Based on this risk assessment, key decisions are made regarding whether a patient has coronary angiography or has conservative management. The management of stable angina comprises lifestyle changes, medication, percutaneous coronary intervention, and surgery. NICE produced guidelines in 2011 covering the management of stable angina. All patients should receive aspirin and a statin in the absence of any contraindication, sublingual glyceryl trinitrate to abort anginal attacks. NICE recommends using either a beta blocker or a calcium channel blocker first line based on comorbidities. If a calcium channel blocker is used as monotherapy, a rate-limiting one such as verapamil or diltiazem should be used. If used in combination with a beta blocker, then a long-acting dihydropyridine calcium channel blocker is used, such as modified-release nifedipine. Remember that beta blockers should not be prescribed concurrently with verapamil. If there is a poor response to initial treatment, then medication should be increased to the maximum tolerated dose. If a patient is still symptomatic after monotherapy with a beta blocker, add a calcium channel blocker and vice versa. If a patient is on monotherapy and cannot tolerate the addition of a calcium channel blocker or a beta blocker, then consider one of the following drugs such as long-acting nitrate, ivabradine, nicorandil, or ranelazine. If a patient is taking both a beta blocker and a calcium channel blocker, then the only added third drug whilst the patient is awaiting assessment, PCI or CABG. This table summarizes the mechanisms of action of drugs commonly used in the management of acute coronary syndrome. Aspirin is a type of antiplatelet that acts by inhibiting the production of thromboxane A2. Clopidogrel is an antiplatelet that works by inhibiting ADP binding to platelet receptor. Enoxaparin and fundoparinox activate antithrombin 3, which in turn potentiates the inhibition of coagulation factors 10A. Bilavirudin is a reversible direct thrombin inhibitor. The Driver and Vehicle Licensing Agency DVLA, Fitness to Drive, has outlined specific guidelines for those with cardiovascular conditions. These are the specific rules. For hypertension, they can drive unless treatment causes unacceptable side effects, hence there's no need to notify DVLA. Disqualified if resting BP consistently 180 mm mercury systolic or more and or 100 millimeters mercury diastolic or more. If they had underwent an angioplasty, which is an elective procedure, they should be 1 week off driving. CABG would be 4 weeks off driving. Acute coronary syndrome would be 4 weeks off driving and 1 week if successfully treated by angioplasty. Driving must cease if symptoms occur at rest or at the wheel for angina. Pacemaker insertion, 1 week off driving. For implantable cardioverter defibrillator or ICD, if implanted or sustained ventricular arrhythmias, cease driving for 6 months. If implanted prophylactically, then cease driving for 1 month. Having an ICD results in a permanent bar for Group 2 drivers. Successful catheter ablation for an arrhythmia, 2 days off driving. Aortic aneurysm of 6 centimeters or more, notify the DVLA. Let's summarize. Initial therapy focuses on stabilizing the patient's condition, relieving ischemic pain, and providing antithrombotic therapy. Additional therapeutic measures that may be indicated include thrombolysis and percutaneous coronary intervention, which is a preferred treatment for ST elevation MI. And if you are encountering high-risk non-STEMI or unstable angina, you want to risk stratify the patient using the Gray score to determine if they need immediate PCI or conservative measures in the meantime. We have come to the end of this topic. Thank you.